Hi, we're Nia and Mary-Anne from Seren Health Coaching. We are metabolic health coaches who are passionate about good metabolic health for everyone. We also love to chat about all things health and to share as much information as we can with people who want to make changes to their lifestyle but aren't quite sure where to start. We're going to release a new episode every Friday where we talk about a different aspect of health. So do subscribe and let us know what you think. We'd also love to know what you're interested in too. So if there's something that you'd like us to have a chat about, do send us a message and we'll do our best to cover it soon. Good morning, Mary-Anne.
Hi, Nia. Freezing
What
cold today.
isn't it
But they,
just? I've got every layer imaginable on.
yeah, I'm sort of hugging the hot water bottle, thinking about the spring that is going to come.
It is going to come. I mean, it can't
Yeah,
not come. This
few
is the
daffs up in
thing.
my garden. They
Ooh,
are getting a terrible fright, I think, coming up and you
coming up
know,
and going, oh, it's too
yeah,
cold.
shouldn't have
Going
done
down
that.
again.
Shouldn't have done that. Okay.
So, okay, well, we're not going here to talk about daffodils,
No,
fortunately,
no,
because I'm no
no.
horticulturist.
Much more riveting subject.
Lovely. So, what are we going to do today?
Well, let's talk about blood test results. What is normal and how it works when normal suddenly becomes abnormal.
Oh,
And the
yes.
reason I started thinking about this is we recently had a client who had interpreted pre-diabetes blood test results as okay and not diabetic for a long
Not diabetic.
time. So,
Yes.
in other words, this got me thinking. So, when we told that we are normal, what does that mean to us as sort of patients that are being screened?
Okay. Yeah. So it's interesting, isn't it? Because pre-diabetes blood test does actually have
Yes.
a middle ground. So because we're using the same blood test as we would to determine whether or not you
Yes.
were diabetic. And in fact, pre-diabetes, that range means you are nearly
Yeah.
diabetic. So
Yeah.
it actually isn't normal. And it's important because obviously knowing that you're a little bit further down the scale means that you have far less work to do to
Yeah.
turn this around. Whereas if you got into the higher numbers, then you've got a bigger job on your hands.
But what was interesting, I suppose, and made me think about it was that this particular client had seen it the other way. So
Yeah,
pre-diabetes means I haven't got
got diabetes.
diabetes,
Yeah.
and it missed the sort of cue for thinking this is actually easier to put into remission now than it's going to be. And if you looked at the trends over those years, that had gone up slowly. So it's not.
Mm,
And you're right. This is the one blood test, if there is one, that's a
yeah.
good example where we have put a middle thing in. But there are lots of blood tests where clinicians use the nuances around normal in a way that patients don't have the wherewithal to read those indications.
Mm,
So, for instance, someone does a white cell count and it doesn't suddenly go from this is normal to this is bacterial.
no,
There'll be
no.
that slow grade, and a clinician looking at a patient will be looking at all sorts of other bits of
Yeah,
that
it's not just
patient.
done on your blood
Exactly. So
tests.
the number doesn't just shriek from it's normal to it's bacterial. So that's
Yeah,
sort of what I'm talking about. And the reason I'm talking more about this, and of course they've standardized blood test results for clinicians because it does make it easier
of
to
course. Yeah.
interpret them and for computers to interpret them too.
Yeah,
So
yeah, yeah.
all of that. But you can get all your results in the NHS now on the NHS app.
Yes, yes. So
And
I'm
this means people are looking at their results and they're looking at the gradings of what is normal.
yeah, so they're doing a traffic light kind of scheme, green, yellow, red. But obviously there's much more to it than just I'm green and then other ones are tipping over from yellow to red and you're like, well, does that mean it's bad or does that mean
Yes,
that we look at other things
exactly.
as a whole or because
And is it because I'm older or is it because I'm on a particular medication or,
mm,
is there some other factor which we, of course, as patients aren't necessarily aware of?
no.
Exactly.
So that's interesting because I think that's becoming more commonplace now. I
Mm.
mean, some people will obviously not look, and that's their
No,
right.
sure. I mean, lots of
Yeah.
people maybe won't.
But maybe now there's more, particularly for
Mm.
us in metabolic health, more people are getting an HbA1c
Yeah.
than before. It's becoming more standard to do
Yeah.
it.
HbA1c test is a great example, actually. We'll talk about it in more detail because I think a lot of listeners might well have had
Had one.
this done for screening. So we'll talk a bit more about what the actual test is screening. It was introduced in 2011 in the NHS, and it really changed our practice.
Yeah. So until then, if your doctor suspected that you had a problem with your blood glucose,
Mm.
they would use these blood sugar tests, which were just snapshots. So
Yeah,
it depended on whether you'd fasted, what you'd
yeah,
just. I mean, if you'd just eaten a chocolate bar, it was going to be high.
exactly, but you
um,
didn't know that.
but you didn't know that, yeah. So there was a lot more testing that had to be done, which was a lot more invasive.
Exactly. So the snapshots were if they were abnormal non-fasting, so you often just did them non-fasting on patients, and then if they were abnormal, you would
Mm.
then fast the patient to do a more sort of sophisticated one, and then that laborious glucose tolerance test where patients were fasted and given a certain amount of glucose, and then you basically had to do enough originally, quite a few blood tests. It landed up only being 2, but
Oh
you were
yeah, but
looking for the
originally it had to
curve,
be, yeah, you had to
basically.
be in the hospital and
Yeah,
have
you
your
have to
blood drawn at
sit
repeated
exactly.
times.
We used to put a
Yeah,
little vent flont thing in and take the blood every half an hour, whatever it was, and you would
yeah,
get that graph, the curve. And by the way, they still use this in testing in pregnancy for reasons we'll talk about later, looking
mm,
for
mm,
gestational diabetes. And also, this would be used in type 1 if you were suspicious of type 1 diabetes because you don't have the history on the blood cells that you need for the HbA1c test. So, those
yeah.
would be the sort of reasons that you wouldn't use this.
I have to say, when I did these tolerance
Mm,
tests, this was the biggest eye opener for me as a clinician to understand
yeah.
what it really felt like to have these blood sugar roller coasters. Because,
Yes.
so when I was pregnant the first time that I had it, I had to go and drink this at 7 o'clock in the morning. So wake up, the
Okay.
first thing you do is have to
Yeah.
chug down this disgusting
Yeah.
stuff.
Yeah. And it makes you feel
Then
sick, actually.
it
Yeah.
does. Then you gotta go to the centre and wait for the nurse to come and midwife to come take your blood. Then you had to sit there for a number of
Yeah.
hours before you could have another one, and then you could go home. And then you walk through the door, you've been out for hours, you've had nothing to eat since this
Mm,
blood test,
mm.
and you suddenly feel like you've been hit by a bus. You
Interesting.
just want to lie down and sleep. You feel dreadful.
Yeah.
And of course, as soon as you eat something, you start to feel a bit better. But that was the
Yeah.
first time that I
That you
realized that,
realized. Yeah.
whoa, what that felt
And
like.
that's the sort of peak of sugar and insulin, isn't it? So,
Yeah,
and yeah, so we understand a lot more about that than we did then.
yeah, yeah.
So this sort of grading, if we go back to the grading of normal, pre-diabetic and diabetic, was an incredibly good addition because we started to talk about this thing called pre-diabetes, which
Mm,
is exactly what we're talking about blood test result interpretation, really. That in the beginning, when we first used HbA1c, it was either normal or you were diabetic.
mm,
And can you imagine before, people being told they were completely normal for years, if they'd had such a thing done, and then suddenly, out of the blue, they were told they had a major chronic disease.
yeah.
And I remember the distress it was caused with absolutely no sort of
No
preamble.
warning. No.
No,
You
and
went from
yeah,
0 to hero almost, but not
yeah,
hero.
I had
Bad.
people in tears, and it caused a lot of things, that as health practitioners we weren't really aware of, but it changed their insurance, and it was really depressing to be
Mm,
told that suddenly, with no warning, that you had a major chronic disease. And not only that, you often a lot of these patients often had family members, of course, because they had family histories.
yeah.
And so they sort of knew diabetes was, a lot of the complications of diabetes were known in these families because other
Mm.
members had had them. And that was also incredibly depressing.
So many people who come to us and say, I've got a pre-diabetes diagnosis. My mother or my father is type 2 diabetic, and I've seen how they've had to suffer,
Yeah.
and now they have to inject insulin, and I don't want
Yes. Yeah,
that.
yeah, sure. And it is very depressing if you think that's what's going to happen to you. And remember, in the old days, I call them the old days, not that long ago, we really frightened patients by telling them all about the complications at diagnosis because we
Yeah,
were trying to make them compliant with the treatment. I mean, that was the sort of way we did it, which,
yeah.
when you think about it, was an awful thing to do to people.
You've just been
And I'm
given
not
the shock
sure
of
it
your life,
I'm
and
not
now we're
sure
just
it
gonna
was very
compound
good
that.
it was very good at the compliance bit either.
No.
Um, so I suppose the HbA1c was a great introduction because we could start looking at that grading.
Yeah, and I think it also meant it that screening and monitoring were much more reliable. You
Yes.
had a much
Yes.
greater insight into how this disease progressed.
Yeah. Yeah, we
From
really started to get a feel for averages. And the other thing was that, remember when before HbA1cs, we asked patients, the only way we had of monitoring their diabetes was asking them to do blood sugar diaries,
oh
with the
yeah,
finger pricks, right?
oh
And it was a real ask of people. And they
yeah,
often brought diaries in that they'd either done,
the day before
yeah, or
or in
filled
the waiting
in.
room.
I mean, we often thought they'd fill them in, or they were meticulously obsessive about
Yeah,
their blood
yeah.
sugars, which was equally bad for their sort of quality of life. So
And
basically,
it doesn't do you any good because,
no,
it hurts some people to do that. I mean, I'm terrible because I've got such cold hands. I can't get much blood out of my fingers, so it's always been painful. And not because I've
horrible.
been asked to do it, but because I was a pharmacist, so we played with the toys.
Yeah.
Um, anyway, that it's a big psychological burden to ask your patient to do that as well, especially if it's
And
causing them pain.
remember type 1 diabetics, who are different because they used insulin right from the beginning. But imagine having to, it seems really odd now, and it's not that long ago. There are probably
Yeah,
quite a lot of type 1 diabetics out there that are still using finger pricks. I hope that most
have
people
moved
in this
over now.
country have got better monitoring systems now. But it's made a huge difference to type
Mm,
1 diabetics and the safety around hypoglycemia because you're having to inject insulin in real time. So it's been fantastic for that.
mm,
The thing about screening the HbA is
yeah.
looking back 2 to 3 months, so you get a mean. It's not a blood sugar result.
No,
It's a
it's a mean
mean, which is
estimate. Yeah.
really useful for screening because it gives you a much more reliable. Imagine
Mm,
just using a snapshot on people. You could just have a good day or a bad day,
mm,
and off you'd go.
mm.
Um,
So let's talk
yeah,
about what that is actually
okay.
measuring and how it works.
The HbA1c is measuring the average amount of blood sugar, which is glucose, in the hemoglobin, which is the part of your red blood cells that carries oxygen. They call it the hemolyzed bit of that blood
Yes.
cell, and it's a protein. And it will measure it over the 2 to 3 months previous, which is the sort of lifespan of a red blood cell.
Yeah.
But you
Yeah.
can
So
imagine you'll get some new ones and
yes, of
some
course.
older ones. So it's a mean of all that. It's a really sophisticated test.
Yeah. So remember your red blood cells are not on a 3-month cycle. They all die
No,
together and then they all come
exactly.
back
They
to
don't
life
all die
together.
and then you get new ones. No. So this,
It's over time.
yeah,
So
yeah.
on a typical day, maybe you're replenishing 25% or something.
Exactly. Quite sophisticated, but it does rely on healthy red blood cell turnover.
Of
So if
course.
you've got any other
Conditions
conditions
like
that might
anemia.
affect that red blood cell, you really can't, they're not as reliable. It'll either send that HbA1c up or down, depending. So
Yeah.
things like anemias will affect how you read the HbA1c,
Yeah.
maybe
Yeah.
kidney diseases. Um,
Okay.
but this was such a big step from that snapshot into something
Yeah.
that measured a mean back 2 to 3
Yeah.
months.
And
Um,
so why is it not used for pregnancy then? Why do we still have to give
ha,
pregnant women this vile test that we all hate?
because remember in pregnancy, gestational diabetes, as they call it, will have developed quite quickly.
Mm.
So unless you've got a 2 to 3 month lag in time,
Yeah,
and the same with type 1 diabetes, it's a much more acute condition.
it's
And so
much more
you
rapid
can't
in
you
onset,
can't
is it?
use you can't
Yeah.
use the HbA1c,
Okay.
but everything else you generally can.
Yeah. Okay. So you go to the doctor. So say when we're not talking about pregnant women or type 1s now. So
No.
you're an average Joe who's going to the
Yeah.
doctor. Perhaps you've got a couple of symptoms like you just feel tired all the
Or
time.
maybe you're just overweight and they use
You're
it as a
yeah,
screening tool.
or
Yeah.
you've gone for something completely different and
Or
they say,
yeah.
"Let's run a panel of tests."
Yeah.
And what comes back is this results. What kind
Yeah.
of results can we get from HbA?
So my argument about all of this, and which is why I started thinking about it, was this business of being told you're normal,
Yeah,
but is there an optimal bit in that normal? So I recently had an HbA1c test done. I mean, out of the blue, I don't know why my GP decided to do it, and I didn't like the fact that I was nearer the top end of normal.
yeah,
And so I said, I don't like the look of that." And she said, "Absolutely not. It's normal
mm,
until." until it's
until
pre-diabetic,
proven otherwise. Yeah.
which I got me thinking, and I thought, "That's really interesting," because in my mind, there is optimal and there's normal, and I
Yeah.
particularly wanna be in the optimal.
And I have
So,
a lot of
okay.
people who say to me, "I've gone back down into normal, but I want to get it lower."
Yes, and I suppose then you've got the danger of people who become obsessed about
Obsessed
getting
with
it
the
very low,
number.
and
Yeah.
and you can see that particularly around cholesterol tests, but let's not talk about them. But it's
Yes.
true too, even with HbA1c tests. I can't remember where they. It's a bit like measuring BMI. So it's all these things. What is optimal for that person? Well, there's a whole lot of different factors that will come in. So in a way, my GP is right. What are you worrying about? This might be optimal for you.
Mm.
But I still think I'd like it to be in the middle of that
Yeah.
normal rather
But
than
we also know, don't we, from just anecdotal experience that often as we get older, our glucose control is a little bit
yeah,
less tight than
for
we would like.
maybe different reasons. Yeah.
Yeah, so other things to consider. Okay.
Yeah. I looked at whether age affects it actually with the hope that it would say it did,
Oh.
but it doesn't necessarily. But of course, there are other factors that age does affect,
Mm,
and we know that from wearing the CGMs that we
yeah.
definitely react slightly differently. So our thresholds are different, and
Yeah, I mean, look, we're not just solely based on our blood
no,
sugars. You've got
yeah,
other diseases, I've got other
yeah, yeah.
diseases. No one gets a perfect body.
No, and cortisol levels, stress, sleep, and all those things
Yeah, yeah,
all affect
absolutely.
the way that you, respond to your fuel, as we know.
Yeah, so
Um,
okay, so there are three options then that we get from these
yeah,
test results. Normal.
yeah,
I love a normal.
yeah, yeah. Optimal
Pre-diabetic,
normal, yeah,
which is between, well, I don't, yeah, it's a small range. It's about 5 points of pre-diabetic range.
okay.
Interestingly different in America.
Yeah, so the different countries will have set those thresholds differently, which is also interesting when you're talking about interpreting results. So
Mm,
you
mm,
would be pre-diabetic quicker
in
in
America.
in America, yeah,
But I think that might have been done as a cultural thing because they are
maybe,
aware that perhaps their
yeah,
overall health
maybe,
is worse. Maybe I don't
maybe,
know. And then obviously full blown type 2 diabetes.
yeah. Okay. And it's good to know, by the way, that in the UK we measure it in the millimole
Millimoles
per
per mole. Yeah,
mole
or millimoles per
scale,
litre.
because
Yeah,
it used to be done in the percentage of glycation,
yeah.
which I loved because I grew up on it, but like growing up on one
It's
money
like
system.
growing up in stones and pounds and then having to
All
convert everything
that,
to
yeah.
kilos. Yeah.
It took me ages to make I used to have a conversion table on my desk because I still couldn't work I liked the percentages sort of
I
anyway.
loved the percentages,
Yeah, I
and
don't know.
in fact, on my desk currently, I'm looking at a Post-it note
Oh,
where I
are
have
you?
written everything out because I'm
Yeah.
so used to converting it all,
Yes. If you grew
and I
up with
like to
1,
have it
it's
that
like a
way.
decimal system, isn't it? Whatever
Yeah.
you grew up I grew up with kilograms, for instance, so I stones means absolutely nothing to me. So
Mm,
it's really hard to get your brain around,
it is.
these different measures. But that just to mention that, because some people will remember the percentage scales. It's
Yeah,
just
yeah, yeah.
reported differently, that's all.
Brilliant.
So there's a broad range of normal. It goes from 25 to 41,
Mhm.
um,
And
and
obviously, we
that's
all want to be at 25, Marianne, because
yeah, and I asked you the other day,
that's
I
the
said,
A star.
"Where would you like to be?" And you see, you did say you'd like to be the lower end of that. And so that's sort of what I'm talking about, really. It's that
Yeah.
nuance of interpretation, isn't it? Um, and within, so if you're looking at normal, that optimal range we're talking about is probably 30 to 35 rather than 25 to 41.
Mm.
Now we pick in slightly at this.
Picking at this. I mean,
Yeah.
this is all done. So, to a certain extent, you can say somebody has set these limits,
Yeah, with
after
a
doing some work and
yeah, of
modelling and
course.
all the
This
rest of
is
it.
this is quite research based.
Yeah,
Yeah.
but we have to, and we have to just take into account that there are other factors that they will look at as well.
It, diabetes is particularly tight in terms of diagnosis because it was felt that it needed to be.
I
So
think, from a personal perspective, and having worked with so many diabetics and pre-diabetics, I think actually it is a good thing that there is that line in the sand because actually, as you said, we have to remember diabetes, although we did scare the
Mm,
pants off people, but it's really serious. It
I
is
know.
serious.
And
So we
that's
have
yeah.
to kind of
Yeah,
put a line in the sand to actually say, you know what, we're not just going to make it okay for you. There is something
yeah,
we need to do about this. We can't just leave you untreated. Whether or not you choose to take the medicine or do the work in lifestyle changing,
yeah.
um, it is still a line in the sand that's
So
important.
So the client who thought that they were pre-diabetic and got used to that over years of being told they were pre-diabetic, what they
Yeah,
didn't get was the trend. And I suppose that's sort of what I'm talking about. So if you were a clinician looking at those results, you would say to that patient, look, this is your trend, and
yeah.
you will
You will
go
eventually
up
get there.
into the diabetic
Yeah,
sort of
yeah.
scale. And that might have meant more than just being told you're constantly pre-diabetic. So you continue to live the way you
You
live
lived.
and you're
I
not
think,
diabetic. I mean, that's
yeah.
sort of what I'm getting at, I
It's
suppose.
almost so I think the benefit of this pre-diabetic diagnosis is we give people a bit more warning,
Yeah.
and if we get the messaging right,
Yes.
we can be much
It's
more
all in the
successful.
messaging.
Yeah. I think it's
Yeah.
all in the messaging, it's all in the way we communicate it. We have to
Yeah.
strike the balance. So, okay, normal, optimal normal, 42 to 47 is
Yeah.
pre-diabetic, and
Yeah.
then as soon as you tip over to 48, it's
Yeah.
type 2 diabetes. But
Yeah.
people don't realize that actually you can go from pre-diabetic, so maybe bumping along at like 45 for many, many years, for example, like this
Yeah.
patient,
Yeah.
and then suddenly
Yeah.
your next blood test is 85. It's a
Yes.
real
Yes,
shocker.
yes, exactly. So it doesn't suddenly become abnormal. That's my point in a way. And your
Mm,
risk doesn't suddenly just change. So
no.
the reason we're diagnosing metabolic diseases in a way is we're talking about the risks that go with them.
Yes.
So
Yeah.
so blood sugar abnormalities are one thing, but it's the risks that it indicates in a way is more important. So you
Mm.
don't suddenly increase your risk. That risk will be increasing over quite gradually,
Over
maybe
time.
over
Yeah.
many years.
Yeah.
Um, and that's, I suppose, what we're getting at. Um, you can see how important it is to look at that range and that trend over time rather than just interpreting the boxes. I suppose that's
Yeah,
what I'm
yeah,
getting at.
yeah. This is the other thing about medicine and that people maybe don't appreciate so much is that medicine is both an art and a science.
Yes,
There is an
exactly.
art to
Yes.
interpreting blood
Yeah,
tests
yeah,
with a
yeah.
lot of experience, with a
Yeah.
lot of
All the
nuance.
other risk factors for that patient.
Yeah, yeah, absolutely. That's why you treat the individual
Yeah.
and not the results.
And that's what good clinicians do, of course. But the
Yeah.
more that we get our own results on things like the NHS app and then interpret them ourselves, the danger is we don't have the nuances. So
Yes. So
it yeah,
there's always Dr. Google and there's
yeah,
always the worried well and over interpretation of certain results. And so it is, yeah, you're quite right. It's about I think there's really good things to be able to have your blood tests in an app and see them.
yeah,
There
yeah.
are and obviously in terms
I'm not
of
sure the doctors think so, but yeah.
well, maybe they would if you going to a
Mm,
different doctor and they couldn't access your results or for whatever reason. I think
yeah,
perhaps
yeah,
it's a good thing overall, but there's going to be a lot of misinformation and education. But now, obviously, there's an optimum place to be within that
yeah,
range of normal, which is true
yeah,
of other blood tests as well.
yeah. Lots of other
And
blood tests.
nothing should be taken in
Literally.
its
Yeah,
yeah, exactly. So
yeah.
that's interesting. So what
I
about
think
though
so.
if you do have an HbA1c blood test result and
Yeah,
maybe you had one last year and it was 40 and maybe you had
yeah,
one the next year and it was 41 and
yeah,
then
yeah,
they say
yeah.
right we'll keep an eye on you and then then suddenly it's 42, so what can you do about it?
Right. So how do you reduce your risks? Well, you exercise,
Mm,
and that comes up, I think, probably at the top of my list. So
mm.
strength and aerobic, but don't just do aerobic.
No, no, no.
Resistance training substantially lowers your risks as your muscles are bigger and more active, and therefore they handle that blood sugar better. Carbs keep them complex. By that I mean basically eat whole foods.
Yeah.
Optimize your sleep, really important. Don't eat just before bed because that means, you're trying to sleep
Digest your
and
food whilst you're trying to shut everything down and
yeah,
repair. Yep.
monitor that
Terrible
waist
idea.
measurement and keep that optimal because that's about your visceral fat. Don't
Yeah.
smoke, which is pretty obvious, and reduce your psychological stress. I like these
Yeah.
glib sort
Reduce
of
your
things.
psychological
Yeah,
stress. Off you go.
yeah, off you go, go on. Um, and it sound so familiar, all of this?
Do you know, I was thinking the other day that actually a lot of the stuff that we use and have now proven to be really
Mm,
effective medical advice is
mm,
based in age-old
yeah.
information that's been passed down, and they may not have realized why it
Yes.
was so
No.
effective, but they knew that there was something in it.
Yes. And if you asked, I don't know, my mother's generation, the themes would have been the same, keeping active,
Mm,
um, keeping purpose in life, keeping connections, eating whole food. And some people around the world don't have the chance of necessarily optimizing all these things.
mm.
But yes, there's no doubt that all the things we've always advocated about optimizing your metabolic health are the same things that will optimize your
And they're relatively,
HbA1c, your lipid profile, your
yeah,
blood pressure, your
relatively
weight.
simple when it comes down to it, isn't
Very
it?
simple.
It's not this magical supplement or
No,
the potion.
unfortunately not. And that's why we discussed things like the GLP-1.
Mm,
And we'll discuss in the future more the weight reducing drugs
then
around at the
yeah.
moment because it isn't good enough to just fill one of those boxes. And just nice to think about that optimal box rather than just saying something's normal or something's not. So
Yeah,
you
yeah.
know, it, and the nuances of being a clinician and using things in a holistic sense, because testing is only one bit of the
Part of the
puzzle.
process. Yeah.
Yeah.
I mean, look, we had previously people had to make diagnoses without the aid of some of these tests. So
Yeah,
there has to be more
exactly.
to it.
Well, I
Um,
I worked with an older GP who'd been around a long time, and he always used to delight in telling me that historically, if you wanted to know if a patient had diabetes, you had to taste their
their
urine.
urine. Yep, I
Yes,
remember that.
he
Yeah.
delighted in that. I
Yeah.
never did do that
I was
myself.
so glad that because pharmacists we used to do it too, and I was
Yeah,
so glad that I was not a
you
pharmacist.
missed that bit.
I don't actually think I could have done it. I
No,
think I'd have probably been just like, no, sorry.
that is
That's
going quite
commitment to the
far
cause,
for
I
your
think.
your profession anyway. I
I
mean,
mean
they
I
also
mean,
chop
it's
people's
like
legs off with that anesthetic,
that's
and
very
a few
true.
other things.
It's like when you have children and you're convinced that you don't know what you're going to do when they vomit, but all of a sudden turns out you can in fact catch a child's vomit in your bare hands because you don't want it to go on your new sofa. So
Yeah, it's hard to believe, isn't it? Children's is always better than anybody else.
that's why I could never have been a nurse, Mary-Anne. I'm
No, I did struggle with some aspects of that. I won't go into it, but I did work on intensive care units with a lot of bodily fluids, and some of it was pretty tricky. I still remember it. I mean, nowadays it's sort of easier, but anyway, let's not talk about that.
anyway.
Anyway, I hope that explains why interpreting blood tests is not necessarily, simple, boxy, easy, and worth thinking about being optimal rather than just normal.
Yeah, absolutely. Yeah. Anyway, have a good week, Mary-Anne. I'll see you next
Yes,
time.
will do. See you soon.
Bye-bye.
Bye for now.